also just some of you are not stretching. Please don't sleep. Touch your toes.
Don't walk, you don't try. You supposed to be jai. Kill up mommy for person, my tongue, person with no man. Boy, when I land softly on his sofa. So far, so good. Pony badger, let me see you. Let me see you.
DJ. Yeah, let's reserve the remaining part for after the session. Yeah, so I'm really honored to chair this last session, and we have a very short remaining part on our program. So, and the session, we have two presenters, then we shall have a general discussion and final remarks from the different stakeholders. So I'm honored to invite Dr. Lucky, so I'm very lucky to invite Dr. Lucky. Dr. Lucky is a senior health economics research fellow at the Health Economics and Policy Unit and chairs the Malawi Ministry of Healthcare Technology Assessment Task Force. So I'm really happy to invite him to come and share with us. Thank you.
How many minutes do I have?
20. Anyway, yeah.
Oh, yeah, okay. Yeah, so I feel very honored to be here this afternoon. Thanks so much, Afidep, and thanks NEPAD as well for the privilege for me to be here and talk to you about the health technology assessment. So really, this is taking away from the technology innovations that we've been hearing the past 2 days. We kind of taking a step back. Okay, so I'm taking you away from the biomedical sciences, the innovations, all the kind of technologies that we've been talking about here, that we've been showcasing. And I'm going to talk to you about the money side. So that's what I'm the bearer of the bad news. So I sit between you innovators and the policymaker, okay, to see that the innovations that you're coming up with, are they fit for purpose? Do they have value for money? With the demands that the policymaker has on which one to take aboard and which not. Okay, so that's basically the essence of this presentation. Dr. Kazim, is this working? Oh, I need to push it a little bit more. Okay, not so. Okay, thank you. Okay. Oh, so it's just jumped here. So as I was saying, in the last 1.5 days, what I've been hearing about emerging technologies, there have been new technologies, those that you can see in there, these emerging technologies, ET. And then we also been reminded about the proof of concept. We've been reminded about emerging technologies vis-a-vis existing technologies. So as we have these new technologies that are coming on board, we don't have to forget the existing technologies. And then outside that, we've been hearing from these different presentations and the questions that have come up. They've been about equity, regulation, ethical considerations. They've been about financing, about sustainability, social issues, governance. So how do you bring all those on board? And this is where health technology assessment comes in. Because what health technology does is brings all those on the same table to help the policymaker, the decision maker, on which one of the technologies has got value for money. You know, we heard about technologies on maternal health. We've heard about malaria technologies, GBVC technologies. The policymaker, which one do they take? Because everyone is so convinced with their technology that it's really, you know, improving healthcare delivery. But there's so limited financing, and so which technology does the policymaker take on board? And that's where health technology assessment comes in. So by definition, WHO, it describes health technology assessment as any new drug, pricing, or infrastructure that is designed to improve health. But in reality and in practice, when we talk about HTA, what we're looking at here is mostly, we're looking at pharmaceuticals, medical devices, and the clinical procedures. So bring all that on board, and HTA is basically a tool for resource prioritization, evidence-informed priority setting. So it could be called different things in different settings. HTA is just one way of calling it. But by and large, it's just an efficient way of trying to consider different aspects and then see which one can be prioritized for the policymaker to take on board. So just give you an example here. If you can see on vaccines, so for example, these are the technologies that you see on your left. And what you consider in the health technology assessment is what you have there on the right. So you consider vaccine in terms of safety. You consider it in terms of clinical effectiveness. You consider it in terms of the budget impact. And then you consider in terms of cost-effective analysis. And that's where us health economists get so excited. We talk about the cost-effective analysis. And then you talk about the ethical issues and all sorts of things. What about the community, acceptability by healthcare professionals, and acceptability by the community? You know, there are so many stories that we can talk about the vaccines for COVID, for example, and how the community also, you know, had their take in terms of whether they should get an uptake on the COVID-19 vaccines. So when you assess that vaccine in terms of all those aspects, that's what a health technology assessment is all about. So what normally happens at the moment is most countries, they are very much committee-based. And so in the committee-based, so for example, what we're saying is, say for example, there's a free technology, an emerging technology that has come up through this, the work of you, senior esteemed colleagues. And with that technology, you're looking at effectiveness, okay, tick. Affordability, tick. Maybe it's been given for free, okay? But financially, it could be free, it could be zero on the books, but economically, it's not. Because in economics, there's no free lunch. If someone gives you a free lunch, someone has paid for it, okay? So it could be free, but there could be some caveats. There could be things that comes along with it. And you need to go behind the iceberg and see what's behind it. And so what we're saying is with the current one, it could just, on that list of checklists to consider, you could just look at the two, effectiveness and affordability. And yet there are things there about acceptability, cost effectiveness that may be not looked into. Or it could be a new vaccine, you know, affordability, efficacy, effectiveness, safety. Okay, the one that you see in purple, or is it in pink? Yeah, purple. And then you got the evidence use or cost effectiveness maybe might not be looked into. Okay, and so these have got a budget impact. And what we're saying is the budgets, especially in our setting, they are very much limited in terms of where do they spend the money. So they can't just invest in every technology that comes up. And that's where the bad news, as I was saying, sometimes comes in, because for you innovators, you know, come up with all these technologies, and maybe some, you know, are not going to be adopted, you know, because there's just a constrained health budget that has to work around. Yeah, so in global, when you see here, sorry about this graph, might be misleading a little bit because it combines both the burden of disease and the and the costs as well, and demand for HTA. So apologies for that. But what it's trying to put across is when you see In high-income countries, you look at the mortality or the burden of disease is quite low, but when you talk about the use of a HTA as a process of resource prioritization, they are very efficient in terms of how they use that tool to guide them. So it's basically a question of a rich person being so considerate in how they use their money. And the poor person, give them money today, they'll just, cook a big nsima or ugali. Not to last them for a day, and they'll forget there's next week and the week after. So that's what we face with. When you look at this, this is from one of the papers that come up recently. I think, it was just talking about the development assistance for healthcare. You can see where we are in the sub-Saharan Africa, that we are so much dependent on the development partners, to finance our health systems. But when we look at that one is taken from WHO, you can see that in countries with very strong health systems, they are using HTA for priority setting. And in countries where we seem to be, we are not really using the tool for resource allocation. So that's kind of the paradox that exists. That those that have got strong health systems, they're using efficient tools, to guide them process in terms of resource allocation. And in fragile states, or perhaps in countries where we're limited in health budgets, we might not have very strong mechanisms for resource allocation. So where we are in Africa, the evidence is there that there is limited use of informed for priority setting. And among the AU member states, I've just highlighted some here. So some of your countries perhaps may not be here, and don't feel offended. I just brought out what I know from literature. So in terms of using of HTA, Ghana in Africa has really set the pace, and Egypt. And then you got some that are upcoming. You got Egypt, Kenya, South Africa, and then you got Malawi and the rest of the world, the rest of the continent. The Africa CDC, through the Health Economics Program, they've come up with a program to help AU member states to have HTA for resource allocation or evidence-informed priority setting. As I said, it could be called whatever it is. HTA is just one name of coining this. Yeah, so they are assisting African states, to come up with a continental framework to assist in resource allocation. So this is just talking on the slide that I was showing you before. And so now I'm going to talk to you about Malawi, so my country where I come from, and where one or two as well in the audience are coming from. So this work comes on the back of the academia, because I work in an academic institution. So we did this as an academic exercise, looking at HTA and the value for it, okay? So when we did that work, we not only looked at existing frameworks, but also we looked at the gaps that are in there. So we did all this work and looked at the limitations that do exist, and then took a step further and took it to the Malawi Ministry of Health senior management team. And so the structure that we have in Malawi, so you got the Minister of Health, and then under him is the permanent secretary or principal secretary, and then after that they are directors for different departments. So at the senior management team, the one who chairs is the permanent secretary or principal secretary, and the directors of health. So obviously, before taking you to the senior management team, we went through we got technical working groups. We told them about this HTA framework and the need, for having an HTA for resource allocation. They bought in the concept, and so they said next step is to take it to the senior management team, where we presented it. So when we presented it, they saw the value of it, and obviously previous work had shown that there was, kind of a demand for having an HTA framework in the country. And so we presented it to the senior management team. I presented it, nerve-wracking, but there we did, and they were able to take it on board. And so they said, immediately you have to institute a task force. This task force should look into all aspects of an HTA. Okay, and then come back to us with recommendations. So this was back last year in April, when. And so what has happened? So this is just a composition of the framework, or rather of the tech task force. So it's made up of Ministry of Health and different departments within the Ministry of Health. And then you've got other agencies within government agencies, and then there are associations, civil societies or local governments, and then academia as well involved, and international or development partners or international partners, WHO, involved in it. And the mandate was twofold. Number one was to evaluate the HTA across 4 pillars. Number one was the governance, the structure, and the legal aspects. Number two was look at the mandate and the principles that would govern an HTA. The third one was looking at the capacity to do actually an HTA process. And then the financing as well. We're talking about the issue of sustainability here. Number two was to look at the recommendations and for an HTA institutionalization. And this one was twofold. Number one, to develop a conceptual framework, and then secondly, provide the recommendations to take it to them. So this is the approach that we took. Number one is we look at the literature review to develop that helped us to develop a conceptual framework. So did desk review and some work that we've done before, looked at the literature. We shaped the conceptual framework. So after developing that one, the next step was a consensus building. So we brought all the task force members involved, as I showed in the previous slide, to build consensually on this framework. And then phase number 3 was to validate the findings for the conceptual framework that we've come up with. So these are the 4 pillars. Number one is the governance and structure, to look at the laws within health in Malawi, where can the HTA fall under? And to us, it comes at the right time, because right now, the Public Health Act that we have in Malawi in 1948, and now it's being reviewed. So this is an opportune time to bring in the HTA into it. It's under revision, so to go to Parliament soon. And then to see in terms of the structure, is it going to be an independent entity, an HTA? Or should it be part and parcel within the ministry structure? And then what will be the mandate that will govern an HTA? And what will be the values or principles that should be looked into when assessing an HTA? And then the capacity, who are involved, to do an HTA process. And then lastly, look at the source of funding as well. So these are the 2 options that we came up with within the task force. Number one, this one is a fully autonomous. So we said, what if an HTA is a fully autonomous, it's a standalone entity? To have a full institutionalized would mean 2 things. Either you can create a new entity altogether, start from the ground, and come up with a new structure. So having an operation or having a governing board and an executive team and the units that will do kind of different aspects of an HTA, which are outlined here. And then obviously patient representatives as well involved, sitting on the body to determine whether that technology is to be taken on board or not. Or the next choice was to use existing structures. So for example, in Malawi, we've got the Pharmacy, Medicine and Regulatory Authority, PMRA, but they've got limited in terms of the mandate that they have. So perhaps just build on the mandate that they have, just put them more to have adoption as part of it and implementation. So new entity, or use existing ones and just build them on the mandate, but as an independent structure. The second option that we looked at, this one is a hybrid. So what we mean by hybrid, it is sitting within the Ministry of Health, but it's got an academia, civil societies, and the private companies as well involved in the resource allocation or decisions that are made. So this is the one that was acceptable to us as a task force. Consistently, we are built on using this one. And also when we took it to the Air Finance Technical Working Group, they approved it. So the last hurdle was to take it to the Ministry of Health Senior Management Team. And I'm glad to say, I presented this about 3 weeks ago, and they approved it. So the framework that we have, three things that I want you to keep an eye on. We call this a three-love triangle. We've got number one, where we say we've got an HTA division, which will be part of the planning department within the Ministry of Health. Okay? So this one will have an HTA appraisal committee. And I'll talk about the shared appraisal committee in the next slide. On the other side, we've got an HSSP3 think tank. Currently, the health sector strategic plan that we have is for 2023 to 2030. But I'm sure that's a challenge that you have in most countries in the region, is you got the academia or different institutions that everyone is calling on the Ministry of Health, giving them, what they've discovered and all that. So they've got different platforms. What we're trying to do is have a national platform where everyone can come in, academia, private sectors, whatever it is, depending on the pillar of the think tank or the HSSP as a platform to help the policymaker instead of everyone pulling them, to different direction and just presenting their findings. And then number three, we've got a policy lab. So a policy lab are different institutions. It could be us in the COHES, it could be AFIDEP, it could be whatever institution is, depending on the work that has to be done to generate evidence. So this is the structure that we have. So within the appraisal committee, as I said, this has been approved by the Minister of Health senior management team. What they have proposed is to have the chair, it will be chaired by the Chief of Health Services. So the Chief of Health Services is just comes directly below the Principal Secretary. And you can see these are the different expertise that are brought in. And these are different institutions where they come in from the country. So these ones will sit on a committee. So when there's a new technology, you have epidemiologists, you have health economists, you have ethicists, you've got legal experts, you've got biomedical engineers, you've got hospital managers. They are all sitting on the committee and to make an assessment of that technology that has come. And to make sure it is comprehensive, it has looked at all aspects. Financing, sustainability, they are looking at the cost effectiveness. So when there's multiple demands that goes to senior management team within the Ministry of Health, coming from different departments, they go to the appraisal committee will rank them, depending on which one should be invested. And they make recommendations to the senior management team. Senior management team then will see which one they adopt. So that kind of bounces to the question that was posed earlier on by Doctor here. And as Prof. Mbali was saying earlier on, that this is going to be addressed in this presentation. Because what we're saying is there are multiple demands against a constrained health budget. Which one does the policymaker take on board? It's very challenging for them. We have to admit that. HTA is one way that can approve or can help with that process to make sure that the work really is lessened for them. So these are the values that we're looking at that will govern that HTA appraisal committee. So they will make sure that we have evidence on cost effectiveness on this technology. Yes, okay. On equity, yes. On safety, no. Okay, we don't have evidence on safety. So what happens then? There's gap in evidence. So it goes to a policy lab. The policy lab generates that evidence. It goes back. So the appraisal committee will make sure that all the evidence is available across all these. And that puts intellectual property because it's fit to innovation or new technologies. There is need to make sure that that is also considered as part and parcel of the checklist to make sure that intellectual property on this one is available. Yes. Has it been done? Yes. Okay. Then it go forward. If not, then please do this before this technology is adopted by the ministry. And in terms of financing, obviously challenging. What we're saying with an HTA process, first of all, it will start being fully subverted or fully funded by the ministry. And then in the long run, what we're proposing is that there could be levers. So if there is a technology that needs to be appraised, there should be, kind of a certain amount that should be paid by the technologies companies to assist with this process. So, for example, I mean, for those of us that work in the universities, we know about the research ethics committees. When we're putting in our research to be, whether to be approved or not, no, there'll be a fee that will be charged. Depending on the region where you're coming from, it could be 10% or it could be a set amount. Okay, so we're kind of thinking about the same approach, that winning the process away from just fully depending on the government. There should be some levels pegged onto it for sustainability of an HTA process. Yeah, so along with it, there is a kind of a VED map as a tool to make sure that there's alignment, because normally what happens is when you agree on a committee to say, okay, these are the guidelines, we look at A, B, C, D, E. When it comes in practice, and that's what we found with our work, is there's a gap. What you agree in practice, what is in the guidelines, and what you do in practice are different. They're misalignment. So with a VEDMAP 2, it's just one tool. It could be whatever it could. Is to make sure that everyone, if all of us were sitting in this HTA appraisal committee, will have this tool in front of us. So we'll look at deciding on which values, okay? And punch in the values, and it produces the results in real time. And then out of that, it ranks which ones or which intervention to go for. It is packaged, and it goes to Minister of Health, Senior Management Team, and they make the final approval in terms of implementation. Just a way to make sure that that misalignment is not there between what is agreed on paper and what happens in practice. I think I've come to an end. Yeah, so the next steps is we're developing the standard operating procedures for the appraisal committee, and sensitizing this work through the members of parliament, and the so that they know and what's coming, but more especially to make sure that HTA becomes part and parcel of the law, so that there is no, jumping the process. Because once it's just a recommendation, a guideline, and there is no kind of legal connotation comes with it, some will be applying it, some will not. Yeah, so we have some time with them, educate them on this one, so that in the next sitting of parliament, perhaps it can go in the Public Health Act of Malawi, which is being revised right now. And then obviously benchmarking our framework to existing structures in the region, especially like Ghana, but also HITAP, which is in Thailand. We've done really well in low and medium income countries in coming up in HTA framework. Yeah, and then making a final report for the Minister of Health. Yeah, so just to end by acknowledging the Minister of Health that really are chairing this, and I'm co-chair, and the partners that are funding us, and then I don't know if Seke was going to, this one was going to go well with Seke. I'm glad he's not here. And then the HTA task force members. So I'm just privileged to be standing here on behalf of the task force members and the colleagues within my team, but more especially for you to be at work soon after lunch. It's very challenging to be here and to see people that are at work. So thank you very much. Yeah, that brings an end to my presentation.
Thank you so much. Very interesting. So I think we are going to do the same. So we shall have Prof. Fambari also come and make his presentation. Then we shall have the questions at once. Thank you.
Thank you very much. I'm sure I've already presented Maria, isn't it? Yeah, please. Yeah, I think as the process is rolling, we've talked about all these imaging technologies and what have you, but then I think you also have to look at what are some of the policy processes that we should be mindful of as we move, with the this, kind of like journey of trying to bring in, these imaging technologies. I think it starts with where my colleague said there, where he said HTAs, health technology assessments, are, are going to become part of the law, so there are no shortcuts. I think in health, we've enjoyed from the fact that, there's this WHO policy. When there's a WHO policy, the thing finds its way into our member states. But it looks like that honeymoon is gradually dying down, one. And secondly, we've been talking about domestic financing, and the domestic financing for health that we talk about. Now you find that the member states are asking the Rex some difficult questions to say, how do you look at this? So I will talk of the African Leadership ALM Declaration, which I think for those of us who come from the science background may not be aware of it. The health colleagues that are here, I know that they work on it every time. So I will have a slide or two on that, and then I will go back to our business. Next slide. Oh, I'm supposed to be doing this, is it? So what did you say? This one is okay. So the African Leadership, Declaration basically came out of a meeting that was basically, convened, I think that's the right word, by His Excellency Paul Kagame when he was president of the African Union. So the chair of the African Union, in 2019, winding up 2019, and this was done, which was 9th of February 2019, where he convened this meeting, the so-called African Leadership Meeting, ALM, and the theme was investing in health. So it was to do with domestic financing for health. Now, in the declaration which was adopted by the summit, because this was on the margins of the summit, the heads of state committed to some of the things that are listed here. One is to increase domestic investment in health and measure progress against benchmarks. Domestic investment in health. The second one was to complement the African scorecard on domestic financing for health with a domestic health financing tracker. The other commitment was to establish regional health financing hubs in each of the Africa's 5 regions, and then to convene African Ministers of Finance and Health every 2 years to discuss health financing and to review progress against benchmarks. And then the other one was to increase coherence on investment in health by improving alignment of bilateral, and private sector efforts to the priorities of the continent and attract further capital, private capital into the health sector. So these are the commitments that are in the ALM. So if you look at the ALM, the declaration, these are basically the commitments that are in there. Now, I think what has become popular, and normally we like taking up that one, is number 1, increase domestic investment in health and measure progress against benchmark. Now, how do we understand this one? So we always talk of those percentages and other view, but let's see now how this leads to what the work that we're talking about on emerging technologies. And I'll take a case study of East Africa. Next slide. Now, the objectives of ALM are to mobilize more money for health, and then you want to have more health for the money, which the colleague talked about, and you want to maximize equity in health financing and service distribution, as well as enhance leadership, governance, and coordination of health financing. So these are the 4 objectives that are there. Now, we find that probably we are busy knocking on the doors of our member states, talking about putting more money for health. Abuja, whatever it is, or country X has done this, or country Y has done this. It's just one of the objectives of the ALM. There are several others. It's an issue of, efficiency, which is in HTA, mind you. It's an issue of equity. It's an issue of leadership, governance, and coordination of the financing. So, this is what we mostly talk about that we have here. that is the more money for health. So advocacy for money, 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 money. Eh? In science, we say the same. Investment into what? In R&D, 1% of the budget. Energy, they also say so much of that, so much of that. So just as Dr. Anguilla said that there are so many of us who are knocking on the doors of, those who have the coffers of the government. So now they also try to find a way of asking us to look beyond whatever it is. Now, if we, oh, sorry. Oops. Yes. So if I went to this objective, which I want to focus on, more money for health, you see, when there was the national national financing dialogue, health financing dialogue, that you did with the other partners, yes. Normally, the financing dialogue is preceded by a background sort of like a report, and I'm sure the same thing SADC, the same thing in the EAC and other places. Now, I was looking at the one for Kenya this morning. Now, the one for Kenya, somewhere under more money for health, so more health for the money, which is objective number 2. It says, research in Kenya indicates that some counties, are able to deliver care at a much lower cost than other counties. So the question now was, how can counties and facilities be supported to improve their cost of service provision based on best practices and learning from others? No? And then he says, this could include developing approaches to prioritize resources towards cost-effective interventions and implement interventions which improve process quality. So if you look at it, it's an issue of cost effectiveness. It's an issue of cost effectiveness. So as we've gone to member states, asking them for put more money into health, here is what EAC got. So EAC, on 11th and 12th of June 2024, you had a partner states meeting, Dr. Team. Is that right? Yes. EAC, you had a meeting 11th and 12th of June 2024, where progress on health commitments was reviewed. And the EAC Secretariat was requested by partner states, was requested to support, member states in demonstrating how some of the ongoing interventions have resulted in improving effectiveness of the healthcare systems through strategic use of resources. So it's like they are basically sending you back and then say, yes, you come to us, you're asking us for volumes. But, they're even saying it there. This was based on the fact that partner states had committed to reorient their health spending to areas that have greatest impact on mortality and human capital development. And then it says these areas include human resource for health, digitization, community health workers, integration services, and the social benefits packaging. So if you look at this digitization, then now, that's where now the technology listing now is going to come in. What they are saying is, if these technologies, you are saying they are bringing efficiency. If the HTA says, go for this technology, can you now build in that as part and parcel of domestic financing? What they are saying is, yes, you're asking us to put money every time, percentages. But we have prioritized some interventions which are efficient, in which case it's more than just the dollar value, but it's also a matter of what is coming out of that dollar. So in this case, we find that there's a strong appreciation that these interventions could contribute to addressing ARM objectives of more health for the money and equity in service coverage. And there's need to document such outcomes. So I think those of us from science and technology who are talking of these emerging technologies, what it is here that basically we need to support this process. of the LAM. Because what's happening here is that we are saying, in fact, probably if I were to go down here, but what you're seeing is this is emerging. And this, I mean, Dr. Otim, this was from your own meeting. And this is the wording that is in your report. Okay? It's the wording that is in your report. What they are saying is that, yeah, it's not just us giving you a check. Can you also look at some of the prioritize? Because we're also investing in that. And these come to the issues of efficiency, the cost and whatever you're talking about. So this is now where the HTA now is going to be biting us. Okay? Right now, they're asking you to support them. Because they're requesting the ESC to support you in demonstrating how the interventions are resulting in improved effectiveness. But the moment they have their own HTAs in place, they are not going to ask you. You see, they will be telling you now, by us having drones in this country, this is how much, this is the outcome from the drones. By us having AI, this is the outcome from AI. You see? So this is an area that we should be looking at. Now, this is speaking to objective number 2 of the area. So it's not really, so we cannot just be comfortable with just volumes of money. Let us also be cognizant that they are also investing through investments in technologies, and they are saying, can we now be accounting for it? Okay, in which case, it's the efficiency of the technology and effectiveness of the technology. I see this again as I'm reading up on something. One of the technologies that I've been talking about this morning, actually, the funders have said, can you tell us exactly what is basically what are the benefits, what is the effectiveness of this particular technology? So even now, even those who are funding the scientists are also asking them. And actually came across a very well-placed document which says, oh, you know what, we have to go and now start running these things. So just bear in mind the fact that this process that is coming to us, that we have to do it. And I think this is where, if you look at the regional financing hubs, these are some of the competencies that you may need in there, among several that you do have. So here we are, healthcare infrastructure and access. If you look at urban areas, better healthcare access and facilities. Rural areas, you find that the facilities are limited, and people take travel long distances to get to medical facilities and what have you. But then, if you look at it, you find that fewer than 50% of Africans have access to modern health facilities. The unequal distribution of healthcare resources between urban and rural areas contribute to disparities in health outcomes. Maria talked about the mosquito nets being used for what? For whatever, I mean, is it whatever it is. But even those mosquito nets, they are not afforded by each and every person in what? In the rural areas. So you find some technologies that basically that are actually able to go and contribute to that fight by actually deploying some of these technologies right in there once, and then you forget about it. Now that needs to be costed. What's the effectiveness of that? The healthcare workforce. We've been talking of shortage of doctors, nurses being being insufficient supply. You go brain drain and training gaps. Now we are saying we are going to overcome this through some of the technologies, the telemedicine that we're talking about, and whatever have you. The question is, what does that translate into in terms of cost and all those things that basically are in the HTA? We claim all these benefits with our technologies, telemedicine and mobile health solutions. They enhance access. Remember, we're talking of access, and then diagnostics, AI, machine learning. We talked about it yesterday, and then effective resource allocation, data analytics. I mean, we're talking about data analytics and what have you. So the question now is, and what members are asking us, if we ride what's happening in ESC. What they're asking, I said, no, guys, yeah, but we are investing in this. Let's take a case of Rwanda. Rwanda is, one of the countries where they have really invested in these technologies. So if you go to Rwanda and say, okay, but what we need you to do is put the dollar into this. They'll say, oh, but we also have other things that we're taking into account. Can you build them into this? So there's an element here whereby I think as we look at the AOM, which basically we have been talking about, our emerging technologies are contributing to effectiveness, which is about efficiency, it's about access, it's about improved diagnostics, it's about efficient resource allocation. Now, the next thing that we need to do, and which ESA has been asked about, is can you now tell us how this contributes to investments in what? In health. It's all about outcomes from an investment. So what we are saying here is that, colleagues, those of us who are working on this, innovators and what have you, let's join hands. There's still work to be done. And I think we have a very important role to play in ALM so that we change the discourse. It's not just the ministers. I don't think it's just not a meeting the ministers of science and technology, ministers of finance. They also have to be health ministers meeting the ministers of science and technology, because this is where the innovations actually come from. Anyway, we got these imaging technologies, I think, which you have talked about. And here is a case in point whereby this is not going just to be a one entity kind of task. And I think HTA gives us that example whereby it's not just public institutions, it's not just AU institutions, it's not just reg institutions. This is work that has to involve government, private sector, the NGOs, as well as the partners, as was being demonstrated. So really, this is about the collective of it all. So I think this is where I want to end my presentation. I think our next task here is now to work towards that. To say, okay, how now do these imaging technologies basically respond to that objective number 2 of the LAM and riding on the HTA. By the way, HTA came out of the WHO policy. So it came out of the World Health Assembly. And if anything, countries now are being asked to put together these national HTA processes and systems. Thank you very much.
Yeah, thank you so much, Prof. I would request that you sit here for yes. Let's have a quick panel discussion if you really have any comments, questions, but thank you so much, Prof, for the insightful presentation. So I'll begin with you.
Thank you for the opportunity. Thank you and congratulations for the powerful presentations. I start with Prof. I have 3 observations and questions. Number 1, the gap in the workforce. Now, nurse deficit. I want to ask you, is it possible, for instance, if a government decide to conduct like a need-based assessment and observe that there are some workforce in some sector of the government that are not required and decide to shift them to the health sector, for instance, nurses? If that is possible, I want you to advise. And then what is the best way to do that? Then another one is how do we manage? Okay, that's for Dr. Lucky. How do we manage your relationship with the parliament? How do you penetrate them? Because most of the time they tell us busy schedules and all that. The software that you developed, that you use in the assessment, developed and invented by the prof and all that, can you tell us more about it? How can we replicate something like that if we're interested in it? Okay, one of the principles, like you mentioned, Dr. Lucky, you said the third pillar, you said value setting, principles, allocation. I was thinking in the value setting, you highlighted quite a lot of criteria. Now, to remove guesswork, that's one of the responsibilities of science. Don't you think it's possible to allocate weight to each of those parameters so that for any choice you are making, it will be based on certain percentage? You can then take the total so that a candidate won't say, sorry, it was biased because difference between qualitative and quantitative research. Thank you.
Thank you so much. Any other questions?
Okay, thank you. So we as a regional body, we are interested in establishing the health technology assessment in member state, in EQUAS member state. But if I look at the presentation you made, the system seems very heavy. And I assume it will cost a lot. And you gave the example of countries using it. I don't know, did you did you visit those countries to find out really what is the framework for conducting this kind of assessment? And this assessment really it cover all what you want to do. Because for instance, if you have a new vaccine coming in, we have epidemics. Really, are you going to wait to do the assessment before using it? Or so, to me, many issue around this health technology assessment. Yeah, so I want to have more light on it. Now coming to Professor Hambali, yeah, I think we are working on the implementation of LMR declaration in our region. But the very issue for health financing is costing. Because the thing is, Gloria made presentation on maternal and child mortality. If you ask people leading with it, how much do you need to end this problem? You have no idea. So really, we organize two workshops towards the implementation of LM declaration. So how to go about the scorecard, how to go about the tracker. And at the end of the day, what we find out is the key issue is costing. Because if you go to a health facility, really, what is the real cost? You don't know it. You don't know. It's just people doing estimate or this thing. And that's normal in the system. First of all, we have to work on to establish a real costing system, because all those issues even around health, even health coverage, or this. If you look at the packages, it's a comprehensive one, starting from primary to the tertiary level. But really, as the primary level, if you look at a health facility, at the very, very primary level, you can ask yourself, how many health professionals we have there? If you have 2 nurses, 1 doctor, even those people will work 22 hours a day. You can estimate what they can deliver in terms of activity and what this can cost. Okay, so you can have the real cost, and if you look at their paid salary or this thing, so if you reduce the salary they already give, what is the remaining cost to pay for people being asked to pay for the primary healthcare? So to me, all the paradigm, we have to look at it. Just do a comprehensive package from the primary to me, it's not realistic for our setting. So this is just some comments, some reflection points following the presentation. Okay, thank you.
So much. Maybe let's take one more, then we can get some responses from the presenters.
So thanks a lot. What I wanted to comment on is what Professor Mbali presented. I think I really like the framing to really put this from the big benefit of these emerging technologies from the perspective of what it does to improve healthcare, especially in the context of the ALM agreements that a lot of our leaders across Africa committed to. So I think that's I just want to pose a big question there from the perspective of the actual evidence, right? That when you look at what so it's like trying to make the investment case for the technologies and so I think the question being what is the what do you actually what is the cost benefit analysis that is being done on this? And I think when we start addressing that issue of more health for the money, when we start looking at efficiency, in my view, this issue is actually much more important than the first one, which is putting in more and more money. Because at the end of the day, there's still quite a bit of money that is spent in the health sector. And when you ask the question, are we getting value for the money, and how do we enhance that value? I think it's really a big question, and so it's just a call maybe for especially for those of us here who are the scientists, the researchers. Um, I tend to think that not much attention has been put on this aspect of research, even when you talk about efficiency. Um, how do you make sure that you can actually measure the level of efficiency now, and if you come up with specific interventions, how are you going to know what has improved? And I think if we can invest more in doing this sort of cost benefit analysis, that would demonstrate for specific interventions what are you gaining in terms of healthcare delivery, whether it's access to services, addressing equity issues, and ultimately reducing the burden of disease. So I think I just want to say, I think for me, this is the big question mark. And even on the technologies then, um, in the end, I think the question about the actual impact from the perspective of not just whether at a practical level this is you might be able to deliver, I mean, using drones, maybe deliver things to the rural area, but to start quantifying this from the perspective of if it's not there, what are we losing in terms of disease burden, or even in, what savings are we getting from using these technologies? So it's, I think, the health economist, Dr. Ngwira here, you guys who are in health economics, I mean, this costing, the costing of the benefits of certain interventions, and in this case, technology. I think we need a lot of these things. They look like given they look like they could be easily understood. But I think when sometimes policymakers have to decide on really putting more money there versus there versus there, this investment case evidence needs to be on the table. And I just feel like maybe in research in general, it's an area where not much attention is given. Thank you.
Thank you so much. So please pass over to our presenter to respond to the next.
Okay, thank you. Let me start, then the economist can deal with the costing and what have you. You know, when you talk of the gap, I mean, shifting people from one place to another. You know, one thing is that, I mean, these are professionals, specialized people. So I would not be competent enough to say that you can move a nurse or a school teacher to go and become a nurse or whatever it is. I mean, really, I mean, they know that better. But talking about what I mean, coming to what you're talking about, and when you look at the demands that Africa, the demands on Africa, if we are to benefit for all these technological improvements, is the fact that there has to be a change in the mindset of a healthcare service provider. You know, I will say this, that there was a time when our colleagues in health, they never thought of people who didn't have qualifications in health as collaborators. You see, I had to go to a medical school, and be called a medical doctor for you to be identified as a health service provider. I mean, when I was in the university, as a professor, you could even see the way we related between those of us who are in the Faculty of Science and those who are in the College of Medicine. Yeah. They belong to a different class altogether. But what they forgot is that the students again that they were taking over from came out of my classroom, because I'm the one who taught them genetics and what have you. And then they went to the College of Medicine, like in my country, Malawi. Likewise, I mean, so what has happened there, that space has been opened up. I mean, I've been in this health for some time. It has been opened up so that even somebody like me, who is a fish geneticist, I studied genetics of tilapia myself. I mean, that's what I studied. I still find myself space in the health sector and still be able to learn all these things and do whatever it is. I'll tell you what, at NEPAD, health was the weakest department. Okay, but what happened was health was now brought to science and technology. So we injected science into it, and then the thing just became very, 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 very strong. It did not take medical doctors; they could not really push the thing. So what I'm trying to say is that now, why am I saying this? I'm saying this because the thing is that if you look at the health service delivery, the people in the core health profession have to appreciate that to deliver on the health demands of a country, it requires more than them. It requires a drone operator. You see, it requires an engineer on AI. It requires an economist. Yeah. So the thing here is that there has to be that change of mindset to figure out that really, it requires more disciplines than what is taught in a typical, faculty of health. So so in the process, I think to me, the low-hanging fruit there, that just recognizing that, then you've got more people to provide the services. I mean, my brother from Esteco, for instance, if he was to pull on his muscles there from Esteco and say, okay, let us support the health department at ESC, you find that the department just grows up, because he basically has got the tools that they need in health. He can do the same with agriculture and what have you. So it's that recognition, I think, that is important. You see? So, and you see that when you look at the challenges of emerging technologies on the continent, one of them is this whole thing whereby, at the same time, also the people in the medical field will also have to open up their mind and be able to learn some things outside the medical, whatever. Because let's say, for instance, if they are going to be using these robotics and whatever, they have to learn from engineers and software, whatever it is. You see, so that is where I see an opportunity that more people have to be involved in. It is not just the one where we say the anatomy of a human being and whatever it is. It's more than that. Then I think just touching on the topic that Dr. Zhu touched on. I mean, really, I think that's the gist of the matter. The thing is that most of us have approached the AOM intervention through advocacy. We're going to advocate for budgets. But let us remind ourselves that this thing demands advocate that goes beyond just budgets, putting money into health. There are even more things. Because if you put money into the system and there's no efficiency, I mean, it's spillage, basically. Yes. So, and this for, those of us who basically are supporters of the process, we're saying, aha, good. So now we now have to struggle and now come up with these methodologies that are going to address this, and costing being one of them. Now, I think the issue of costing, I'll leave it to my colleague here because this is what is in the HTA. But I know of one typical scientific project going on the continent where actually they are now busy trying to say they're going to bring in this component into their technology. So which means, it is important. I think I will let my colleague come in. I think there are persons, but let me ask the economist. Thank you, sir. Yes.
Yeah, no, thanks, Prof. Yeah, so quite a few questions from Dr. Aziz and Dr. Zhu. Yeah, so I think, first of all, your questions, number one was regarding managing relationship with parliamentarians. Yeah, how has this happened? I think there's been quite a collaborative effort. I think in Malawi, I'm sure this is the case with most AU. For government workers, they can be moved from finance to health and then move to defense and so forth. We are in a right space right now where we have colleagues within the planning. So our entry point within the Ministry of Health now is planning department. And we've got colleagues in the planning that are really passionate about, our work area. And they've seen the importance. Unfortunately, like the director of planning, he's did his PhD in health economics as well. So he can see the reasoning behind all what we're doing. So I think the strong collaboration that comes between the research institutions or universities with policymakers is important. As I said, the work started with just, as an academic exercise and find its way to the policymakers. And then at the same time, the work that AFIDEP is doing. No one can run away from what AFIDEP is doing in Malawi, in my own country. When it comes to bringing people, decision makers, parliamentarians on board, they just set the pace. And we can't work in isolation without AFIDEP, for example. We have to recognize our strength. Unfortunately, within the work that we're doing on HTA, there were some colleagues within AFIDEP as well that were on board in the development of conceptual framework. And so the leveraging on the platform that is existing, on a health platform that lays right now, we found ourselves in the right place at the right time. Yeah. The issue about replicating the VEDMAP, we can discuss that. That's not a problem. But that also hinges on exactly the point that you mentioned, or the last question that you had on allocating weight. I would have gone back to that slide because what it does, it ranks, on those value sets, on those principles. So I try to run away from value sets because when you talk to a health economist about our value sets, we talk about utilities. So utilities are the one when we multiply by time, you get quality adjusted life years, you get qualities. Okay, so that's the opposite of dollars. Yeah, so I tend to run away from value sets. So that's put stroke principles. Yeah, but the point, nonetheless, the point still remains that what we've done with that framework or that app is we have, from the, say, for example, if a country decides on the 16 values to look into, which one should be given more weight? Which should be primary? So it had to be decided. There will be team of experts to determine, oh, okay, out of these 10, these 4 will be the primary one, which will be given more weight. And these 6 are auxiliary. So they'll be given maybe 50% accordingly. Yeah. But it is on that slide. Yeah, but I can talk to you through that. Yes. So that's definitely part and parcel of it all. The questions from Dr. Zhu in terms of integrating HTA member states, thank you for the effort that's being done. And I think the Africa CDC is also encouraging that. So the health economics program on that one. So I was last year, I was here in Nairobi, the Africa CDC, the health economics program that is there, brought all African Union member states to talk to them about the, continental framework on evidence-informed priority setting, for example, HTA. It does look heavy. I agree. But at the end of the day, what we look at is in the long run, it's a cost benefit. Okay? We can run away from it, but are we putting in more money, more resources, and trying to run away from this infrastructure that perhaps will be saving? There will be more cost saving in the end. Okay? But also at the same time, how do we want to start? Do you want to start huge or do you want to start small? So examples, for example, in Thailand, as I said, in low and middle income countries, the one that I've said really set the pace is Thailand. What they did was just, they looked at the cost of medicines. And that was a huge saving from the pharmaceutical world when they did that. And the example that I was mentioning here in Ghana, they also did the same. And what we're saying is start small. Yeah. It can be a huge program, very ambitious. You can't do the whole this thing in just a single day. NICE, for example, in the UK, who, they are globetrotters. I mean, they've set the pace for HTA. It has taken them 30, 40 years to be where they are now. So all what's required is just start small, pick up one, and you will see the benefits that come from there and build on it. Yes, visiting, yeah, on my last slide, I said about benchmarking. So that's exactly what we want to do next, is to visit countries that have implemented this. I did mention about Ghana and Thailand. So we want to take our framework and show them, and this is how we want to do things, and get their feedback and comment on it, and see how we can improve on it. Yeah, so don't be alarmed when we come knocking on your door asking for funding to travel to these places. Right. Yeah, and I think going back to the point that I think we were raising to Prof. Ambali in terms of the costings, what we want to do with HTA is have an electronic system. Have an electronic system across all the costing. And at the moment, there is I don't know if you come across this one, it's called a Tanzila Onse whole disease modeling. So it basically brings not just considering one disease area, it's bringing all the diseases in this model, including the workforce, and get the outcomes. So basically it's a time machine. And it's a model that's being, brought out to other countries. And yeah, maybe sooner than later, you see it coming. But it does look at the costing from every aspect, looking at whole disease, including the workforce, and see the outcomes that come from that. Yeah, so I think I will stop there. I think I've addressed the questions.
Just one thing here that I think if you look at this, the AU institutions have got a task here, whereby there's need for coordination there as well. Because, you see, I supervise the rollout of the regional financing hubs on the AUDA side. It was in my department. But I think we were more inclined towards more money for health. You see, and he's talking about advocacy and whatever and have you. And in the process, you find that we are lacking. There has been lack of clarity. Maybe things now have been clarified in terms of the actual role of the hub. What is the hub supposed to be doing? So now, our client as Rex are member states. Now, member states are now making demands on us, because look at it this way: that for EAC, I mean, this is their report. It came from member states who said, "Hey, can you now give us support in doing these assessments for us?" If the hubs were functional there, which I hope they are, it means that basically it is within that hub now that they will be doing that. But at the same time, if you look at this from another dimension, the very fact that that request came from member state, then they are saying, can you look beyond just more money for health and look into other components of investment? You see? Because it also happened in science and technology. There was this thing of us beating on member states. Oh, member states, oh, their Africa, their contribution is peanuts. Whatever. They said, by the way, can you quantify how much we invest in you using the labs that we built, the staff salaries that we pay you, and yet you participate on a project? They say, can you quantify that? Tell us how much we are contributing through that. And that's why now we find that in science and technology, the language has changed. You don't just talk of the percentage of your GDP. People also saying, can you also look at so what you call in-kind support, and put it as part of the investment. So I think, all it is here that we just have to think through this and then see as to basically, how do we now, serve member states? Because at the end of the day, we are serving member states. How do we serve them better, so that we respond to their to their demand? I thought probably that's what I learned from this exercise. Thank you.
Yeah, sure. Thank you so much. I think we need to give them some good claps. Sure, thank you so much. So I will now hand over back to Dr. Justina to moderate the last session. Thank you.
Thank you very much, Dr. Wasua. And thank you, Prof. Dr. Nguira. Thank you so much. All too soon, we've come to the end of our two-day meeting. And so at this point, we would like to give the Rex a minute each to make some remarks. So we had planned to finish at 3:30, and it's already 3:30, but we want to keep to our word. So a minute each, just to make some remarks, brief remarks in closing. Okay. Should I call, or you just go ahead and present? Okay, EAC. Then we have Comesa. Oh, Comesa, you already stood up, so it's okay. Ladies first anyway. Okay, all right.
All right. Good afternoon, everyone. I know it's afternoon, so after a big lunch. So good afternoon, everyone. Okay. We've been given 1 minute, so I'll try and keep it short. And I just want to start by really thanking the organizers, AFIDEP and AUDA, NEPAD, for organizing this. And not just this, but even the session that we had in Malawi, which I think this is really a follow-up to. And now I know everybody here would attest to the fact that this has been a very, very, very productive session. We have learned a lot. We have gained a lot. And so I'm very grateful for having included COMESA, and I hope and I would love to remind you to keep my email close. Keep inviting us. Keep inviting us. Yeah, and additionally, I want to thank everybody else, the Recs, the experts that have shared experiences. We've learned a lot, and not just in this room, but over the snacks, over lunch. People have been sharing what they do, and it's very encouraging. Partly also to see some of the challenges that others are facing are the same challenges you're facing. It's encouraging. They say misery loves company, but I think it's good to know that as others have overcome, so shall we. So it has been very good to have learned and shared really experiences with everyone here. So for the closing remarks, I just wanted to just touch on a few things that I've picked from this meeting. I can't say it all, but one has been just, as I've said, learning best practices. We've heard a lot from the EAC team. And the other thing has been better understanding the role that Recs play. It's always one of those muddy areas, gray areas that we're not sure where we come in. But I think I leave here with a better understanding of where COMESA as a rec comes in. I'm looking forward to being a link to the member states and being an advocate for emerging technologies, something that is really a niche area, something that's very new. So as a health expert under COMESA, it's great to be able to take this to the member states. I also want to just reiterate how the different presentations have really elaborated and made it very clear the potential for these emerging technologies. And this is really, again, a follow-up from the meeting we had in Malawi, where different member states had come up and shared some of what they are working on. And so we've been picking points of areas that we would love to support as COMESA. And so really to be able to do that support, I picked up three things and three quotes from our different presenters. Number one was, we need to look at homegrown solutions. There's a lot we are doing. There's a lot we are doing here. We don't need to beg, we don't need to copy. We need to look within and build from within. To do that, we need to overcome the mindset of fear that has held us back. I really loved that. And lastly, we need to learn from those that have done it before, those who are wiser, and also from our past mistakes going forward. And so as I conclude, I'd like to state that COMESA is really in a unique position as regards the health area, partly because we're just really starting up the health desk, and it's a unique and very good spot to be in at this time, because we're incorporating. I've been all ears in this meeting, incorporating and thinking of ways to bring that into what we are putting down as we go forward. So as far as the next steps are concerned, we're looking at, I'm looking at incorporating a lot of this into the soon to be developed or developing COMESA health strategy and policy. We are meeting with member states, focal point persons for health very soon in December. This will be definitely top on our agenda. I'm also thinking about incorporating and collaborating with other other divisions in COMESA. You know, with the presentations I saw here, there's a lot of room for the areas of industry and health, industry and agriculture and trade, gender and youth, all that are very accomplished divisions and units at COMESA. And so bringing them on board indirectly benefits COMESA, the COMESA Health Desk at the very end. And so there's a lot to go home and do. And I think the last thing I'll say is that it's very clear that we cannot work alone. And so I encourage you to collaborate with COMESA as we look forward to collaborating with you. So if you hear of anything good, if you are developing something good, reach out. I think there is no reason why we should reinvent the wheel. So thank you once again, and a safe travel as you head back home.
Thank you very much. Can we now invite EAC?
I would say that she has spoken on behalf of all the Rex. I think she has said virtually everything I wanted to say. But since I've been called here, I think I can repeat. One, I want to take this opportunity to thank AFIDEP and AUD and NEPAD for organizing this dialogue. I think it was really time well spent. I also want to take this opportunity to thank the presenters. Well-researched work presented with a lot of passion, belief. It touched us so much and we have really learned a lot. I think the most important thing now for us is to ask us what is the way forward. In the next meeting, in the next dialogue, we need to ask ourselves from the time in Nairobi, how far have we gone? I think that will be very important. But I want to add that as EAC, we are very open to further engagement. I know that Esteco has done a number of good things. They have made some good strides, but there's also a lot we can actually learn from others. And we really want to benefit from the experts so that we can be able to carry this forward. I noted that really there is clear evidence that we need to leverage on these technologies in order to help our people. But like it was said that we need to own many of these things, especially the aspect of funding, because you'll find that for the partners, there could be some specific areas which they are not interested in. So you'll find that probably even some of the countries which have made strides, they could be supported by partners. Suppose the partners now drop, what happens then? Then you find that those countries which have been listed, you find that there's actually nothing which is done. I was chatting with my people from Uganda, and they were telling me that the Infectious Disease Institute is doing a lot of work. Then somebody just made a comment and said it's just research-based for a short time. So I was very upset with that comment. But of course, the reason is that, all the funding they get is actually from partners. It's not from the government. So most of the things they do can be kind of experimental. If the partners are not interested, then they'll not be able to sustain it. So we look forward to continued engagement. I'm happy that there's already a WhatsApp group. The WhatsApp group should not end by, the time we are dropped at the airport. I think we need to continue engaging. And then we need to really see what we can do. So thank you very much. I want to wish all of you journey masses and you continue engaging. Asante sana.
Next, we'd like to invite Esteco. Esteco is represented. Okay, thank you. So we have IGAD.
Good afternoon. Yeah, so me, I would like to start by saying I am so full of information. Yeah, surely the objectives of why we came for me as a person have been achieved. I've learned so much. So with that, I want to appreciate the organizers, AFIDEP and AUDA NEPAD, for organizing such an engagement with the REX and bringing on board experts to really share their work and empower us with great knowledge around emerging technologies in health. How we use that information now, it is us if we can fail to put this to use. But surely, I want to say that one of the main things that I've learned here, I've also made I've networked, and I know that with the networks that I've been able to make, I will be supported to put the knowledge that I have gained today to use. There is a lot that we can do that I have learned, especially the usual words that we use as REX: collaboration, cooperation, coordination. Yeah. These words, we can put them to use in science, technology, and information and make a difference with our member states. So surely, thank you so much. All those who are traveling back, safe journeys, and we promise that we will do this information, will use it effectively to transform the region and the continent at large. Thank you.
Next, we'd like to invite Sadek, followed by Waho.
Okay, thank you. I'll just say all protocol observes, and thank you so much, because there's nothing more to say. We have said it all, actually. We we have said thank you. That's a good opportunity for us to be here, but we just hope that we're going to continue with the same team, including more and more knowledge, more inputs from different sectors, different stakeholders, and also to understand exactly what's going on at continental level and regional level. So for us, we are open to work with all of you, and also to make sure that we push the agenda so we are not left behind as a continent. Thank you so much for the invitation. Thank you so much also for thinking of us in this opportunity, and we hope that we are going to continue that way. Thank you.
Ok, je suis pas un militant pour le français.
I'm not trying to promote French, as it were. Well, riding on the established protocol by those who spoke before me, I wish to
Oda NEPAD et puis AFIDEC pour l'organisation de ce dialogue, pour nous avoir associés à ce dialogue. Je remercie aussi nous tous vraiment pour les échanges qui ont été faits, pour les interactions. Ceci étant, vous savez, à la fin des événements de ce genre, je te pose toujours la question, qu'est-ce qu'on a fait? Qu'est-ce qu'on a fait? Ce que je retiens, on a reçu beaucoup d'informations. Essentiellement, il y a les règles qui ont présenté, mais je pense qu'il y a beaucoup, disons, des résultats de recherche qui ont essayé, qui travaillent dans les laboratoires, qui ont partagé.
from work that has gone on in the laboratories that have been shared with us here as well. We are part of those who are supposed to implement or push for implementation. We have therefore received all this information, and certainly we are just but delegates because we are representing institutions here. That means through us, those institutions need to receive the information that we have gained in this workshop. That is the reason why I insist that the entirety of the presentations shared here be availed to the various participants so that when we go back home, we can share them with our teams so that our colleagues that work on the various thematic areas get to know that we have specific issues to be considered. I have a colleague that works in programs on maternal and child health. I would want to share with them the presentation done by Dr. Gloria so that they know that we can approach that issue with new tools. All the issues that we have, we have colleagues working on them, and at their level, they need to get information through interacting with countries. It is true that we have what is happening in the countries, but new tools are coming up, and we can take advantage of those to move forward. After that, our role as a REC, we need to see how we can have that organized and implemented at a regional level through relevant strategies for implementation. We already note that actors in the RECs need to know what we're talking about. So briefly, that is what was on my mind. And as I said, I encourage AUDA and NEPAD to continue bringing RECs together, because that is what will eventually create continental integration that we are all looking forward to. It's important that all actors get to know each other, and that really compounds their force to move forward. This is a very important thing. As I said, if you have workshops or whatever you're planning, we need to have that mandate. As you know, it is obviously your mandate, but it is our hope that you continue bringing us together. That is what I would wish to say. So once again, thank you very much, and I wish you safe travels back home. Thank you.
Thank you very much, Waho. At this point, we'd like to invite the representative of the AU High-Level Panel on Emerging Technologies, APET.
Thank you so much. And I really take this opportunity to thank all of you for the great insights, presentations that you have really shared. This was very, very, very informative. As a panel, we are really always happy once we meet other stakeholders. And one thing I really want to assure you that the panel has taken time to really look and investigate these emerging technologies. And now our next steps is to see how do we really accelerate the uptake of these emerging technologies on the African continent. We don't just want to have these white documents, good documents, because we know that even if once we have these good reports, but if there's no implementation plan, we may not actually benefit from these reports. So APET has been trying to find out how can we accelerate the uptake of these emerging technologies on the African continent. We have been thinking about, could we really look at academic institutions as the ambassadors for these emerging technologies? Could we look at the innovators as the ambassadors for these emerging technologies? Could we look at the private sector as ambassadors for the emerging technologies? But yesterday and today, when I was in my room, I was like, oh, AFIDEP deserves a gift. Because of this engagement, I've just realized that actually the RECs are such a great opportunity to accelerate the uptake of these emerging technologies. I've listened in, and I think I have a lot of message to give to the chair, and actually say, I think RECs are really a very, very good opportunity to really promote the uptake of these emerging technologies on the African continent. So these dialogues are really very, very important, and I thank the AU NEPAD. Surely, thank you so much for the excellent work, and AFIDEP for inviting APET, and we are always happy to come and participate. AFIDEP has always got some good insights from the APET reports, but also from these discussions. Also, APET keeps picking up insights and action points from this discussion. So it's always a win-win situation, and we are always happy to be part of these dialogues. Thank you so much.
Thank you so much, Dr. Waswa. Next, we're going to have AUDA NEPAD, and then AFIDEP to officially close the meeting. However, before that happens, we have a Mentimeter. So our colleagues from AFIDEP will take us through that.
Yeah, thank you so much. So we just have to go through these few questions just to see, to have feedback from your participation from the day we started yesterday and today. So yeah, you can use your phone or your laptop, just type menti.com, or you can scan, yes, you can scan the barcode, or you use the, yeah, just Google Menti, menti.com, and enter that code on top. Good. Yeah, I hope we are all there. All right. So menti.com. Okay. Yeah. We can only see the picture. Let me see. Yeah. We just wait there. Sure. Yeah, I want the picture. Yes. We're all there, right? We're all seeing this picture. Okay. If you can see this picture, then we'll take you to the next page. Menti, menti.com. Just search on Google, menti.com. Menti.com, and you enter that code. Yes. Just find this page, then we're good. Are we all there? Okay. All right. So we go to the, then, all right, give it a thumbs up if you've done it, so that we know how many are online. Almost all of us, right? And then we go to the next question. Where are you from? You need to know your countries, where you're coming from. So we have Uganda, Malawi, Ghana, Burkina Faso, Nigeria, Zambia, Tanzania, Ghana, all right, DRC, this one. Ah, no. This, huh? It has kicked out some people? Oh, to the code, mentimeter.com. Who else has been kicked out? All right. Yeah. Okay, fine. Uh-oh. Yeah. So, which lake are you representing? And then, don't know why is it not responding. Ah, okay. Oh, okay. Think I'll collect that. Gender. What was your expectation for this dialogue? Collaboration, networking and learning, knowledge and experience sharing, productive discussions, sharing information and learning, collaboration, learn on other regional blocks and see how we shared common best practices to understand the challenges and opportunities ahead as well, foster collaboration beyond ticking the box to action, sharing experiences, resource mobilization. Have you met your expectations? Yes, partially, no. What was your favorite part of the dialogue? The presentations, dancing, GBVCs, STISA 2034, mosquito gene editing, presentation on the last panel, presentation, music. Great. Please let the organization and the quality of the panel discussions. What was the quality and also the organization of the panel discussions? Was it good? Was it very good? Was it neutral? Was it poor? Was it very poor? Please let the organization and quality of the presentations. Very good, good, neutral, poor, very poor. No, I think yeah, it's choosing one. Yeah, it's one. Oh, you can choose all. Oh, that was just a mistake. Yeah. No, that was a mistake. Yeah. Yeah, you just choose one. Mm. And that was just that was a mistake. You know, I didn't test it. Next question. Name one thing you learned that you did not know before this dialogue? What have you learned? Something that's so new to you. Anything new that you've never heard before? GBVC, blockchain, HTA, what what lake does, activities, the great work done by lakes, AFIDEV. Oh, somebody has never heard of about AFIDEV before. Impact of take on MCH, STISA, HTA, structure of the various lakes. Right. Next. One of these persons was on fire on day one. Who is it? It was burning. Next. Please let the below statements. The dialogue deepened my understanding of the critical role that different imaging technologies can play in improving health outcomes in Africa. How would you rate that? The dialogue disseminated the recommendations of APET on the application of the imaging health technologies in Africa. The dialogue shared regional and also country experiences on the application of emerging health technologies, and the dialogue discussed the actions needed by government and other stakeholders. The dialogue gathered insights to inform APET ongoing work on emerging technologies for health. So under each of those, how do you rate it? That's a scale of 5, strongly disagree and strongly agree. Those were the objectives of the dialogue. Let the extent to which the dialogue provided insights that will enrich your work so that when you go, you'll be a different person. To what degree will that happen? So yes, the dialogue provided very useful insights for my work. Yes, the dialogue provided somewhat useful insights for my work. The dialogue did not provide any useful insights for my work. Next. What actions will you take following the discussions at this dialogue? So when we go back to our places, what are we expected to do? What are we going to do? We're going to do some implementations, follow up with legs, collaborate more, share the colleagues' knowledge gained, reach out to experts in different themes and collaborate, discuss with colleagues and incorporate in work plans, share with the authority and implement, disseminate knowledge gained from the dialogue, engage with delegates or on partnership and collaboration, work with legs to regulate, to do regulatory and policy frameworks for emerging technologies. Yeah. Next. In your opinion, what specific priority actions are needed for Africa to accelerate progress on the adoption of emerging technologies? What could be very specific priority actions that Africa needs to accelerate progress on the adoption of emerging technologies? An enabling environment. We need a baseline study, awareness creation, more cost-benefit analysis, that's investment case, clear regulatory frameworks, capacity building and political will, capacity strengthening, collaboration with all stakeholders, enabling an environment, development of policies and regulatory framework, develop tools that will create an enabling environment, awareness creation, accept change. Yeah, thanks. Okay, good. Prioritize the health needs, funding, HTA's evidence. Yeah, next. What are the top 3 priorities for your sub-region for which you need technology, you need technical assistance from AUD, NEPAD, AFIDEP, and other development partners in regard to emerging health technologies? Policy frameworks. So some need technical assistance on policy frameworks, regulatory frameworks, infrastructure development, adaptation, funding, regulation, biotechnology policy, policy development, funding for the implementation. Next. In few words, state your main takeaway from the dialogue. What is your main takeaway from the dialogues in few words? Educative, ETs are the future. It's possible. We need to adapt. Educative, African governments must stop adoption, must support adoption of ETs. The need for collaboration learning, collaboration learning and learning. STI is critical for advancing health on the continent. Robust data is key. REX collaboration. Next. What issues or topics should future dialogues focus on? What issue or topics should future dialogues focus on? Advocacy, BVC, cost-benefit analysis, policy frameworks, research, social diplomacy, funding strategies, science diplomacy, implementation, research, support for intellectual, funding strategy, adoption of ET for here, ET for here, collaboration, okay, cost-benefit analysis, private sector engagement. Next. Please let the organization and coordination of the following. How was the dialogue venue? What about the French and English translation? Coffee, tea, snack breaks at the dialogue, travel visa acquisition process. How was it? Welcoming participation at the on arrival. How was your arrival? Registration of the participants, accommodation, transportation of participants during the dialogue. How was it from here to where you're being accommodated? Next. Please provide suggestions on how to improve the quality of future dialogue. How do we get better? More days. So the 2 days was not enough. More time. We didn't have enough time, but a lot of content. Sharing much info early. There's some information that we needed to be given out before. Send agenda early, thing similar to that. Maintaining a diverse group of presentations. Yeah, that's a recommendation. Group discussions on present questions. Have excursions in focus areas. And with clear action plan. Member states involvement as well. Industry inclusion. Bring different expertise, including youth, private sector involvement, more music, more dancing. And with clear action plan. So a clear action plan is needed at the end. half-day visit of the city. We're supposed to break off earlier today for the last day. Yes, next. Thank you for participating. Yes.
Thank you very much, our colleagues, for the Mentimeter. At this point, we'd like to call Dr. Elia Zulu, Executive Director for AFIDE, to kindly give his closing remarks. Thank you.
All right. I think it's been, although it says short time, but it's 2 days, a lot of information, a lot of insights. I think for me, part of the most exciting was just to see what the RECs are already doing in this area. I think it's an area that is full of a lot of stuff going on. How do we consolidate? How do we pick the ones that are going to really have the most promise for, for scale up and for reaching out to most people? I think that's the key thing. For me, I think if we look back 2, 3, 4 years from now, I don't know how many meetings we all look back on and assess and say, I don't know. I think we were at lunch and somebody was talking about how people sometimes just think about the next meeting, the next meeting, the next meeting. So where will this meeting sit? I think it relates to the evaluation there to say 2 years from now, what will we say? If we had stayed home, what would we have missed? Yeah? Or if we were at another meeting. And I hope that in the end, we'll be able to come up and say, that meeting helped us build something that, especially for me, this issue about the important role of RECs. Africa is so fragmented. Just look at the geographical area, 55 countries. The only thing that can help to bring things together is regional integration, because then we look at more countries come together to optimize the synergies, to fill gaps where people are not doing well, choose who is doing well rather than everybody doing the same thing. So I think regional integration is very key. At AFIDEP, in our new strategy, the 2025 to 2030 strategic plan, we've actually included regional integration as one of our areas of focus, because you can't work in every country, you can't replicate. How do we make sure that these platforms really work for bringing cohesiveness, work for, augmenting impact of what other countries are doing? So I think I'm really very, very excited. I think for me, I'll look back and say we had some side meetings with some of you during the course of the time, just to say, okay, if it's SADC, whether it's ESC or WAHO, I mean, what are some of the things that can that we can work together on? So we look forward to working together more intensely with the RECs. But there are a lot of these technical experts who are here who really contributed so much, sharing their experiences and so on. Many of them from the universities, research institutes. We just want to thank you as well for your contributions. And I think for me, I always look at this issue and say, unless the African universities and research centers take their think tank role more seriously, this continent can't get where we need to get to. They are the intellectuals, they are like the people who have, but many of them have a hands-off approach to development. We like pointing fingers at the politicians for what they are doing or not doing. But in the end, I think the point is universities need to go into the development processes and play a more proactive role. And I think those of you here, the academics who are here, the people from the research organizations, you are shown that you are cut out really well. And if we have more of you, we have to be ambassadors. Let's go and recruit more people to come and engage with policymakers. So I can go on and on. I think it's late. People should have some sunshine, look at the city. It's just to thank all of you. Our partnership with AUDA NEPAD, I think it's really been very, very beautiful. I think we We love it at AFIDEP, and the team from AUDA, and I think you communicate to the leadership as well there that we are really grateful for this partnership. I think it shows that together we can own and drive this development agenda on the continent, and we are ready to do more to take to step up this partnership to the next level. And I would like just to thank also Dr. Rosa Ronje, who is the captain of this ship at AFIDEP, for the work that she's doing, working with everybody, with Auda NEPAD, with the experts, Professor Ambali, Justina. They just look like the guys now who are part of the extension of this Dr. Ronji's department. I mean, they are really helping to carry AFIDEP forward. And the team at Auda NEPAD, everybody here, Maria, I think you are the captain also on that side, right, of the ship. You are really doing a great job, Chifundo, and everybody else from Auda NEPAD who is here. So I just want to say thanks a lot. And those of us who traveled from out, travel well. Let this be, I don't think it's probably, I mean, maybe saying the beginning is not the right word because we've been engaging, but let this really be seen 3, 4, 5 years from now as an amplifier of the great work that we are all doing to take this continent to the next level. Thank you.
Thank you very much, Dr. Zulu, for these excellent remarks. At this point, we'd like to call Mr. Lukovi Seke to give the closing remarks on behalf of AUD and NEPAD.
Thank you very much, Dr. Jacina. I will be closing, but starting once again, or continuing what, emphasizing further what Dr. Zulu said. First of all, I would like to congratulate our undercover heroes, our IT specialists, the cameraman, the interpreter. It's not easy the way we're speaking here. Thank you, very fast, but you manage. And also our team from AUD NEPAD, AFIDEP, you have been busy without sleeping the last few weeks. We have to congratulate you. We know these things. When I was assigned to handle some meeting to make sure that we don't fail Prof. Ambali, we were leaving the office sometime at 1 a.m. Yeah, it was not easy because people will see it was successful, but people have been underground working. So we are really proud of all of you. Before I continue, I just need to let you know that when you read African Institute for Development Policy, we don't have a development policy, but you understand why they wrote it like this. If they ask you, what is your policy for you to grow, to develop the way you are, they sent you at school, you went at church, many things. Or your national development plan is a holistic things with various stuff. So it means that when we handle STI policy, AFIDEP is handling that. When we go to health policy, AFIDEP will handle that. So everything that is related to development is holistic. You have various aspects coming, defense, environment, all those aspects. So really we are proud as AUD NEPA to work with a very powerful think tank like this. Congratulations once again, Dr. Zulu. Keep it up. We are so proud of you. And because of that, we are now seeing the importance of involving think tanks. The World Bank put on the table 50 million to allow think tank to start thinking and something to manage, to continue thinking, to advise our government, because we are observing that think tank are not biased. And for that, we really congratulate the Sahara Institute, Dr. Jacina, for really continuing the spirit of what we're doing at NEPAD, Prof. Ambali with HDRAS. We are so proud of you for really not just looking yourself, but contributing to support the continent. We understand that the 2 days, some said that 2 days are too little, but it's not easy for decision makers here in the venue. You have to approve a thing from your office. it's not easy for you, really, for you to do that. We have to thank you very much. So, so far we had 5 regional economic communities, COMESA, EAC, IGAD, SADC, and ECOWAS through WAO. We need to strengthen other REX, Dr. Zulu. We went to Morocco with Prof. Mbali, and we visited UMA. We were surprised that they were not having an STI desk. Is a bit pity. So we need to handle this thing through a triple nexus, because education and STI report to a single portfolio of ministers. We can have now health. We have education, STI, as well as health. Probably we can have all of them. And we also thank WAO for updating us that in the future, we don't need to write to Dr. Roland because you are in charge. Fully fledged, dedicated entities in charge of health matter. So we learn from that indeed. Also, we have a PhD makers, Dr. Bubakar, who was very vocal, who did react when they asked us to choose a male, female, or none. He said no in Africa. And we just need to tell him that he's lucky because he's part of AFIDEP meeting. Because in Nigeria, they would fire you because Nigeria is part of the United Nations. And then you are failing your country because, so we just remain quiet where we feel that is not according to our view. Those we are on earth indeed. So I'm not saying that I'm from that part, but just to warn you that you need to be very careful when it comes to official meetings, because those are things that countries endorse without us giving the go-ahead. So we also congratulate really the African Union high-level panel on emerging technology, Prof. Gassama, who was not part of this meeting, but well represented by Dr. William Wasawa. Thank you for being there always for us. And we are planning to develop a new proposal with the University of Nairobi, with the support of all the think tanks on a domestic financing tracker. So we believe it's going to be successful, and to start counting down the agenda, the 2030 agenda, and we need all of you. To all REX, really, we thank you, and we need us to continue this spirit for us to achieve the implementation of the forthcoming STISA 2034. And anytime you have any budget line and you feel that you can host us, we are going to continue the WhatsApp group. We share some of the information. If you feel that you can join us during the Science Forum South Africa week, please join us. We can send you the invitation. But if you feel that you have a pocket of budget to sponsor yourself, that is part of us owning our own programs. The issue of language, it has been raised, and I will not go back to the Mentimeter. It's a done deal. We are going to improve based on that. I don't need to cover it as well. So everything that didn't go very well, apology for that. But we did our best not to fail you. And we are proud of that as AUD NEPAD and AFIDEP, and we are taking your message. So far, everything has been done successfully. We learned from your contribution, and we really congratulate all the moderators, all the entities, Ghana, Tanzania. So really, we thank all of you for sharing with us all those information. So without monopolizing, since we have another African Union, European Union meeting to start in a few minutes, they were waiting for me as a co-chair. So we really need to thank you, and we really invite you to really be part of these instruments where we are implementing programs on public health, green transition, innovation technology, as well as capacity for science. Various universities in Europe are taking PhD candidate and master's candidate from Africa. We need you to play a key role to host some of the European entities in your institution, and also to join those institutions during visits. They need you, and for that, you need to join some of those meetings. It's very important, and we are going to use, once again, the same WhatsApp group. So with those few words, we don't need to monopolize, and we just need to say, have a safe journey. May the heaven with you, indeed, in case you can accept that heaven can protect. If not, we just accept that way. Let us meet again soon. So, but I believe you did enjoy your stay in Nairobi. And then if you have a few minutes just to move around, don't hesitate, but we are going to meet once again. With those few words and considering everything that has been said here, we are closing this meeting and we wish you all the best. Thank you very much.